Welcome to Samaritans Purse International Health Forum, and I want to thank you for joining us today. We hope that you all participate in our conversation. You can chat with us in the chat box beside the video. Before we begin, let's open in prayer. Father God, I want to thank you today for this opportunity for us to learn from our brother and colleague, Tim. May we take to heart what you have for each of us so that we are better prepared to serve those who are hurting in devastating circumstances. We thank you again for this opportunity and give you all the glory in Jesus' name. Amen. Tim Mosher is our guest today. He's a family nurse practitioner with over 30 years of experience as a registered nurse and is currently working as a nurse practitioner in emergency and urgent care. He also served as a firefighter and paramedic for 33 years, retiring as a fire chief. Tim has traveled about 25 times to several countries in the past 10 years on mission trips. His 5 dark employments with Samaritan's Purse include serving in the emergency field hospital in northern Iraq last year, treating Ebola patients in Liberia in 2014, and bringing medical aid to earthquake survivors in Haiti in 2016. And earlier that same year, I had the privilege of working with Tim at the EFH in Ecuador. So I know for a fact that we will learn a lot today and be encouraged. Today, Tim will present triage and patient flow management in the emergency field hospital.
Thank you very much, Cindy. It's a privilege to be here today. I want to welcome all of you aboard for this next 45 minutes or so. I know it's hard to find the slot in the middle of the day to take time out for this, and I pray it'll be worth your while. We all come with a different set of expectations as listeners, and I hope there's something here that you're encouraged by today, and perhaps some of you are new to the DART team, and you'll learn about some of the process and procedures necessary to run the EFH. I've seen several of these presentations over the last couple of years, and I found that they vary from time to time. Some are very didactic and formal, some are very informal, and today's discussion will be a little bit more informal. And with a little bit of storytelling about the EFH. One thing that I find very satisfying is it seems like most of the procedures and processes we started in the beginning in Iraq with the field hospital and patient flow and triage kind of continued on over the months. And so this was a point of satisfaction for all of us. I know there are probably some of you out there that were in the field hospital, and hopefully your experience will mirror what I found there to be the case also. So let's remember as we go forward and start our presentation today that this is specific to the EFH. Sorry, we'll start back at the beginning. This is just for the Samaritan's Purse EFH, Emergency Field Hospital, and not necessarily for other situations as we talk about triage and patient flow, although most of the general principles will still apply depending on where you're at. So our purpose really is to talk about our experiences, what we learned, and to consider that the whole of patient flow in the EFH is predicated on what happens at the front door, so to speak. The triage ER area kind of sets the tone for the rest of the hospital, and one impacts the other, and we don't think of it as an isolated area that is kind of an end unto itself, but we always have to begin with the end in mind. And this is my third experience in a field hospital. Back in 2010, I was in Haiti with the University of Miami's field hospital for a week down there in the triage ER part there too. So I have learned a little bit. One thing that's unique about this topic is it's not something that can really be studied empirically very well, or at least it has not been. And so I guess you have to take experiences for granted and put them in the context of what you're trying to do. Unfortunately, today, what we don't have time for in talking about the EFH is ethical issues, how ministry was done, and the tremendous spiritual adventure that it really was, HR issues in this context, and lastly, handover of the hospital, which is a big issue for us to constantly try to figure out how to hand over the hospital. So those are all things we could spend individual sessions on. I'm just going to focus on triage and patient flow today. So we want to talk quickly about the context of the ministry and what the point was for those of you that may not be really aware. In 2014, ISIS had invaded this part of northern Iraq, Kurdistan, and had completely taken over Mosul and had pushed toward the town of Erbil, which you'll see on the slide there on your left. And their advance was stopped. However, over a couple of years, ISIS was wreaking havoc, and it continued to torment the population, killing and hurting a lot of people. So the Iraqi government began to push back with coalition forces and push them back to the edge of Mosul. Well, during that time, hundreds of patients were being transferred out of Mosul to Erbil on the highway, and it was a 2-hour trip. And so many patients were dying en route. We all know about the golden hour concept. And so you can imagine the effect that it had on the civilian population. The patients did get transported in ambulances, but they really did not receive any medical care. These were really just vehicles to carry the patient. And because one ambulance did explode in Erbil early on, they mandated that the patients would have to transfer from ambulance to ambulance up to 4 times before they got to Erbil. And we saw with our own eyes as we began to go out to the field hospital one day, patients that looked nearly dead being transferred from one unit to the other for the sake of safety. So this had gone on for a while, and that was the purpose of the EFH, to get right up close outside a mortar range and be there to intercept these patients and give them the best chance they had. This was done under the auspices of the UN, and it was really an amazing opportunity for all of us that were involved in this. And I'm certain a lot of us will talk about this for years to come. As far as the expected patient load, it was uncertain at the time. We didn't really have any figures. We had no way of knowing how this was going to go. And as a triage officer at the front end, I was assigned to be triage officer and develop some flow policies for the ER. This was a very big concern. I had a mental image of having a full hospital with dozens of patients outside the walls, dying and bleeding to death, with us not being able to do anything about it. And as the Lord would have it, this never happened. And part of this was due, in fact, to our fearless leader, Dr. Tenpenny. He gave us the permission to close the doors if we felt we needed to, if the hospital was overwhelmed. And for me, this was a good relieving effort. And it's always good to put a picture of your boss in your presentation. It just helps smooth relationships. So thank you, Dr. Tenpenny. Real quickly, I want to throw this slide up showing the EFH stats, because a lot of people get an idea of the scope of the job by the stats. The total of patients over 4,000, half of which, surprising to us, ended up being women and children under 17. 350 special forces, and the remainder of those were men of military age, 15 to 18 and older. Some of those were suspected ISIS, some were civilians. It was hard for us to sort that out. So that was a major part of impact on the EFH and especially triage. The hospital was set up, and it took almost 2 weeks. I believe it was 11 days. And that gave those of us that were on the front end chance to practice. It's always hard to deploy quickly and then sit, but the Lord allowed us to use that time very productively to practice our triaging, practice our care, especially in the area of ultrasound. As we got closer, probably half of the team would go out during the day and begin to set up equipment, because in this particular case, we could not just start seeing patients and roll forward as the hospital went up. We had to be completely prepared to do surgery the moment the hospital opened. And so it was a little bit different in that effort. As you become familiar with Samaritans Purse and DART deployments, you will come to appreciate your logistics people. These are phenomenal men and women that prepare long before we go and then put this hospital up. A couple of pictures here to give you an idea. We worked behind 12-foot high concrete walls surrounding the whole area. And we could talk a lot about just the tremendous logistical setup, but you come to appreciate how important this is for what we do in our work, and especially at the EFH. So we're going to move forward now and talk about the actual process. And remember, we're talking about the process of triaging patients, moving them into the facility, and getting them care as quickly as needed. Now, I put this map up here, this picture, this schematic of the hospital, not for the details, but I wanted to just point out down in that lower left corner, you will see this circular area. And the way the patients would arrive to us would be only by ambulance, and they were stopped at the street by security, and then they would call us and let us know what they thought it was. The ambulance would pull back to this circular concrete driveway that was created and stop. We would not go out to the patient, but we trained national Iraqs and Kurdish assistants to help us, both men and women, and they would go out and they would get in the back of the ambulance and they would undress the people completely. Security would then wand the patient to be sure there was no metal or suspicious items on them to help protect us. And then the patient would be covered, and then the patient would be brought inside. And this was for our own protection. So it was difficult to be inside, staff sitting there when they said they may have, say, 4 or 5 patients in the back, critical injured, and you're waiting for even 10 minutes, 15 minutes perhaps for a patient to be secured and brought inside. But that's the nature of this kind of business. So once the patient was scanned, undressed, and they would be brought through the steel doors, and this picture you see here that I've entitled Through the Door really has a lot going on in it I thought would be interesting to you. First of all, you see on the far right is one of our security guys there watching what's going on. They weren't always there, but they always had a really good feel for what was going on with the patients and the risks posed to us. Then you see to his left, Katie is at that time the triage nurse. She's ready to greet the patient right outside. We did not take the patients inside until they were evaluated. And this patient clearly was either a female or a child, because the woman that is leading the patient would have gone out to help assist with that. If it's a male, generally the men would handle it. You have the mix of the nationals here, and then over on your far left, you see a soldier at the door who's armed, who immediately closed the doors. And so this was all set up to protect us and evaluate the patient outside before they're brought into the hospital. And that went very well. Now, the setup inside, and we'll get to some pictures here shortly to the inside of the field hospital, was pretty straightforward. The triage officer would function alone and hand the patient off immediately and decide were they green, yellow, or red. And those of you that know about triage may know about what's called START triage, simple triage and rapid treatment, the acronym. And we're not going to explain that today. You can go study that yourself. We also used advanced trauma life support guidelines on patients regarding making them red, yellow, or green, based mostly on respiration and pulse rate. And so at this point where you see Katie in this picture, if the patient were a green, that would be a patient who's very stable, does not need immediate care, would be literally directed around the trauma bay tent to the ER proper and settled in there. And the patients that were yellow and red would immediately go into the trauma bay, where 1 physician and 2 minimum nurses, 3, maybe sometimes 4, if we had plenty, would be assigned to the patient. And so there were little clusters of people managing each patient that came in. And one thing I'll talk about again a couple times is that we had the luxury in this position with the triage officer, ideally would function as the overall ED manager. Because when you have several patients, you have lots of staff, and there's a lot of busyness, and you have different needs of lab work, x-rays, or maybe a patient needs to go to surgery. Someone needs to have a feel for what's going on. And this is one of the main things I want to come out of this talk today, is that we always have someone who's kind of managing flow, because frankly, a lot of us would rather just be taking care of patients. That's what we do. That's what we love to do. But someone always has to kind of have the helicopter view and know what's going on. And so the triage person is the logical person to be able to do this, that they can get disconnected then and go back to triaging if more patients come in. So let's take a look at kind of the original setup. This picture here was the first trauma bay that we had set up, and we found that it was rather small. Even kind of the entranceway here gives you the feel that it was small, and it was 4 beds at that time, and we felt like it was enough until we actually started to do it, and then the numbers of patients went up too. And as you can see, this is an amazing, first class place to work, but we did run out of room. And this is the kind of busyness that got to be in there. Now this is, we'll go to the next slide, and you'll see on the left, this picture was taken in the 6-bay trauma room, and this made a big difference in being able to manage patients. And this seemed to be adequate, at least in my experience, for the numbers of patients that would come in. I don't ever remember patients waiting outside to come in. There was one incident I had known of, I think in March, perhaps some of you were there, when there was a cafe explosion in Mosul, and there were at least 30 patients that came in. I think that was one of the really bad days I'd heard about. But overall, this was really a very effective setup. If you notice, the cots are placed at a certain angle to move the patients in a certain way to make it flow easier. But you may have 40 people working in here at one time, as this picture kind of gives you the feel for. Busy, very busy. It can get noisy, but then this is where your triage officer, your ED manager, whatever you want to call them, can function to help keep things calm, keep things moving, and move people around as needed. So I want to stop here just for a minute and talk about some triage concepts that we want to think about when dealing with triage in the EFH. And it's really true across the board when you think about triage. One of the first things is that triage is preparing for downstream care. You're thinking constantly about where the patients are going to be going. It's not a matter of looking at a patient saying, oh, they're red, yellow, green, black, have a nice day. We're trying to get the patient somewhere to get more care. And a lot of times this includes dealing with pre-arrival information. And by that, I mean, sometimes we would get information by radio. Sometimes we get a phone call from an outlying hospital about sending us a patient, or you get a verbal report. So you're always dealing with that pre-arrival information and putting it in the context of what's going on right now. And when you think it through, does the hospital even have the capacity to deal with this patient at all if we're full? So you're always thinking about the impact. When there's very few patients and the hospital's not full, it's pretty easy. It's not hard. But sometimes it's a very big deal. Also, triage by its very nature can be constant or sporadic, and we found that to be the case. Obviously, it's like working in an ER. For those of you that work there, working for EMS, you might run a lot, you might see a lot of patients, and then it's quiet for a while. Our experience there was we didn't really do any at night, occasionally, because the ambulances would not run at night. So the other things we might have seen were some kind of tangential incident or trauma that was brought to the hospital. So it comes and it goes. Triage also likely happens more than once to a patient before arriving where they need to be in the hospital. And this concept of re-triage is something not a lot of people consider. They kind of do it, but they don't realize that consciously. Re-triage is something we're going to talk about a little bit more here today too, because things change. A patient comes in, the triage officer maybe didn't recognize a certain injury on the patient that makes them a red instead of a yellow, or vice versa. Maybe they made them a red and you get back in and you realize they're stable, their pulse is stable, they're breathing well, they're not losing any blood. They're a yellow. And that's normal. We have to accept that. It's kind of really, to a degree, it's a value-free area when you're making these decisions. If someone changes your standing or group of people, it's fine. It's the way the system is made to be. We're helping each other decide what's best. And so it's not a competition to see who's going to be right about triage. And the last thing I listed is that triage personnel may be needed for post-triage care, And by that, I mean people working triage and even in the ED, by my particular standard, was that when they're not busy, they're to help out in the other parts of the hospital as needed. And this was especially true at night because we often had people assigned to the ED, but you may not have any patients at night. And so the staff was really good about helping out in the men's ward or in the ladies' ward or wherever the need was, because we're a team and we're not going to isolate people not doing anything just because I work in X department. And the staff was really, really good about that, and because that's what we're there for. So we're going to take a little trip through the EFH here to give you an idea, for those of you that weren't there, what this looks like. And we don't want to get bogged down in any of the areas. Although we could, there are just so many great people doing so many things in the hospital. It's really it's mind-boggling and inspiring. This picture here is of the emergency department, and this could be expanded at times between 14 and 20 patients, especially if they were green and they were sitting. So you could have a lot of patients in here without any problem. Patients that were moved from the trauma bay, stabilized, and maybe were now preoperative, would usually stay in this area if they were stable. So this was the area with the largest mix of patients going on, and it was potentially the most chaotic area for that reason. I know a number of times we shunted some green patients in here and filled the place up pretty quickly, and the patients were sitting without getting any attention immediately. So when staff was trying to work and get things together for different patients, it was who was doing what for whom and what needed to be done. And that's kind of the nature of it. But there again, I'm going to go back to this idea that you need an ED trauma bay triage manager that's keeping an eye on all of this, or you'll have things happen that shouldn't happen. You'll have poor communication with surgery, with patients going to the ward, with patients being pre-opt. So you got to create a good flow. You got to keep track of all of this. And since I have this picture up, I want to point out at the back of this, if you look straight forward, we had created a barrier, a cloth barriered area for patients that were convalescing, is what I call it, that were going to die. We made them black, but they might linger for several hours. So we created an area in the back of the ED where they could be attended to, or if they were deceased, we could do what was necessary to manage them and get them on their way out. So that happened in the ED also. This area here, the overflow area, was the original trauma bay, and we found it was a really terrific place to set up some of the administrative things. And yet when we had a lot of patients, especially greens, we could tuck them in here, sitting in chairs, and get to them when we could. So it really worked out well for that, and that change up happened without too much difficulty. I want to talk, before we look at the other areas, about all call. And this, what we mean by first call, second call, all call, this was to manage surge events when too many patients came in, or a lot of patients came in and would put a lot of pressure on the ED and all the other departments. We had a method of calling people according to predetermined lists. So every day, the nursing supervisors that made the staffing for the day would indicate on the board who would be listed on first call from each unit, and then who would be on second call, and then all call would be everyone, where we would wake everybody up. And I know we did this several times and it worked pretty well. And the idea, if you're not really familiar with pre-hospital staging, is very similar to this. It didn't work well if the nurses and doctors that were on the first call coming to help us from other areas just rushed in and started taking care of patients. No, they needed to come and stand by in a group, and then we would go grab people and ask them to go to this patient or this bed or do this for us. So it's a controlled environment. I don't remember how many times we did all call, but we were reticent to do that because you don't want to really wake night people up during the day, which is when it would happen. But it was there, and I personally don't know of a time that the hospital was completely overwhelmed and unable to manage the patients. And this system was part of it, and I think it worked pretty well. Keep in mind that your patients are headed to multiple places in the hospital. They might go to surgery, they might go to a ward, they might go outside because they're deceased, they might go to the ICU, they might go to death convalescence. And so your goal in this ER is to keep control and get them directed. Chemical decontamination, this did happen once that I'm aware of, that I was there. This is the one exception to the outside rule. You can see in this picture, the staff is literally outside the walls, but there's a secondary set of walls there on the picture to your right that they're still working behind for the most part. Although we were exposed in this particular incident. We did have suspected mustard gas, total of 9 patients, so they had to go through a decontamination area. We did train the national staff as well as we could in decontamination. But this is something that somebody with some experience has to have if you're going to perform this correctly. So this will always be part of the EFH consideration and patient flow. We'll move on past this particular slide and go to the ICU and step down. We could talk endlessly about the tremendous staff we had in this 4-bed unit, taking care of patients. Really, the patients came mostly from surgery out into the ICU post-operatively. Occasionally, a patient would go there preoperatively and would get round-the-clock care. These include ventilators, IV pressors, and all the modern things that you can imagine. And a lot of the ethical decisions actually got made here. Sometimes we think that there's all these ethical thoughts out in the ED and the triage, but I think our experience in this case was the difficult cases that were lingering, had multiple surgeries. They created some very difficult decisions that had to be made in this ICU. Next area is our secured area, which I took this picture at night because right up front, we didn't really take a lot of pictures. And there was a special area that was secured extra with an extra concrete wall that we put all the males of military age, and this is where they were taken care of. So the nurses had to carry a lot of equipment back and forth in and out of here. Obviously, the focal point of the EFH is surgery, sterilization unit that went with it. The national staff ended up running the sterilization unit, and we have 2 surgical suites. Amazing things happened in there. Here's just an outside picture of what the patient wards look like. Up to 50 patients can be treated in the EFH. You could probably squeeze a few more in. This is where a lot of the work happens. The nursing staff in there working with all the patients and all their post-operative and tertiary care issues. So I always want to give them a lot of kudos for that hard work. And we always want to be communicating. One thing I did see happen a few times as an aside was in the ER, patients needed admitted, maybe to make room, and they were just taken to the patient ward without any forewarning. Well, you wouldn't do that in the hospital. You wouldn't just dump a patient on the hospital floor. We don't do that in the ward. So good communication, getting the patients where they need to be when they need to be there. All right, well, let's talk briefly about retriage. Defining repeat triage as making ongoing rationing decisions between those already being cared for and those not yet treated. So we're always considering where we're at. And as this is an area that hasn't really been studied much, the only thing I found online recently was a study put out by the Israeli military on their experience in their field hospital in Haiti in 2010. And I was actually in that field hospital when I was down there and saw them working. And they discuss in this article, if you want to go look at it, a great deal about the decisions made on continuing decision making in a field hospital and triaging patients. Should we let new patients come in, for example, if we're having trouble taking care of the patients we have? And I have a couple examples. If a patient deteriorates while waiting on surgery, should she go ahead of other patients? That happened quite a bit. Let's say our surgery's backed up 24 hours. There's so many patients. This is going to impact triage decisions. And I know of a couple cases where a patient that was red was migrated toward a black status because there was no capacity to get them into surgery fast enough. And so this is difficult. This creates a lot of pressure for us. If our patient wards are full and we're at our limit, do we take more patients into the EFH? Who makes that call? Who's going to do that? So those are examples of how these ongoing decisions to ration care versus those are cared for that will come up. Shift gears here just a little bit. I want to talk about use of national staff. This is something I think Samaritans Purse does very well, and it's always a large part of what we do for a number of different reasons. But in our EFH experience, they are an integral part of triage right at the very beginning. They don't determine the level of care, and they're not really involved doing medical things, but they're involved in translation, determining where the patient came from and what's going on. So this is a little bit of chaos because the doctor, nurses are trying to talk to the patient through translation. But we also need basic information, name, age, where they're from, or if it's a child, who the parents are, and all that kind of thing. So this is an area that takes a lot of patience, but we really had great staff in Iraq. And we got into a good flow where they knew what we wanted, and and they would help deliver that for us. They also would do anything we asked them to. If you had a patient that's bleeding and you want them to hold a bleeding artery, certainly they would do that as they begin to really get a feel for patient care. In Iraq, they also operated the X-ray equipment in the trauma bay and in the ED, and that took a while to get up to speed. Originally, we were doing that, but over time, they assumed that responsibility. And a large part of their activities were in moving patients and transporting patients. And until you're in a setting like a field hospital, you don't understand how big of a deal that really is. Just the physical movement of patients and how many people it takes to move patients. And by them doing all of that, it keeps our medical people on task, not moving patients around. And so after a time, they knew exactly what to do. We told them where a patient to go, and they would get it done, and it was really great. So that's always going to be a feature of your EFH. And lastly, I wanted to point out that a significant area of national staff usage was that for the chaplain and in getting patients discharged. Because obviously we're there to share our faith, we're there to show Christ, we're there to talk with patients, but we have the dynamic of the medical to deal with. And so by having national chaplain staff there, they can focus solely on that, and we work with them. And also, discharge, it's hard to appreciate how much work is involved with discharging patients in this environment. You have children, maybe don't have any parents. You have people who, because of ethnic reasons, don't want to go to one area or another in the country. Different hospitals they would or would not go to. I counted at one time, there were at least 9 different places we were discharging patients. And so every day it was a fairly big ordeal in the morning to figure out discharge. And the national staff would help us do that. They would also be in contact with the family and keep them updated about what was going on in the field hospital. But as far as the front end of the hospital, most of the national staff involvement was in translation and information gathering. All right, we're gonna go and talk a little bit about the triage officer. I have some thoughts that I've developed, and you can see them listed here. And lots of people are capable of doing this, but first and foremost, you should have some kind of experience in emergent patient assessment. And part of that is dealing with the difficult visuals of traumatic injury. If you're not used to that, it can be a showstopper for you sometimes, and it can interrupt your thinking about triage. If you medical folks out there think about the first kind of awful thing you ever saw, I think probably all of you can say, yeah, this is what it was, or that's what it was, because it really had an impact on you. Over time, you become more accustomed to it, and it doesn't really interrupt your thinking process. So it can't be somebody that's a complete novice, obviously. On the other end of it, a lot of people think that, well, an ER physician is the perfect triage officer. And on the one hand, that makes perfect sense. But in a practical sense, in the field hospital, I don't want my ER doctors out there doing triage. They need to be in taking direct care of a patient. They need to be assessing the patient's level of injury, because all we're trying to determine is red, green, yellow. So that's my opinion about that. And I think perfect people are people that have a lot of EMS experience, because when you work in the pre-hospital setting, you're used to chaos that really exceeds what happens in an ER. That's not to say an ER can't be chaotic, but I've worked in both fields for a very long time, and pre-hospital is a unique thing of its own. And this kind of triage has that kind of an element to it. So people with EMS experience are good. The other thing is, if you offer to be the triage officer, you may not provide any direct patient care. And as I said before, we all want to be doing patient care, and so you may be disappointed that you're not actually doing that directly, especially if you're trying to manage the flow in the ED. You have to know your own emotional limitations. When I was in Haiti in 2010, running the ER there, a doctor from Texas came in one morning, and in 4 hours, she was an ER doc. She came up to me with tears in her eyes and says, "I can't do this," and she walked out. She had no idea that she was going to reach some emotional limit with this chaos and this heat and the visuals. Someone who I assumed, well, this is great. An American ER doc should be perfect. She walked out. So there's an element of knowing your own emotional limitations when it comes to doing triage and even working in the ED. You have to be able to cope with these pre and post triage pressures, the issues that come up that are going to impact the patient flow, especially in the ED. And we always need to have a second triage person in mind. You should always be developing someone that can take over for you. And we did that actively. In the field hospital, people are going to need a break. They're going to need to leave after a couple weeks. They may get sick. They may have a particular emotional problem for a given day. So you always have to have a number two person. And I'm real big about that. And so the person that's doing the triage, if you're like assigned to do that and you're the main person, you're going to have to sacrifice a little bit of your own desire and have somebody else do it and get experience doing it. Okay, as we begin to kind of wind down toward the end here, where we're going to have some Q&A if you would like. Lessons learned. This is all we can do is share with you lessons learned. And most of this is from my point of view, obviously. First of all, too much detail to triage staff before the patient actually came through the door ended up being more of a problem than not. And by that, I mean, when we would receive a radio message outside the compound about a patient had this injury or that injury, or we had 6 patients or we had 2 patients, and by the time the patients would come in, it would be all upside down and be different. That was a problem from my point of view because everybody would ramp up for X patient and Y patient would come in. So it's better just to wait until the patient comes through the triage area and then you can adjust. Red designation is a tricky color because red might be red-black, red might be red-yellow. Who defines red? Is red red right now because the hospital's full, or is red really red because the hospital's empty? So red's very tricky, and especially because it's considered a critical patient. Yellow, there's a little more fudge room. So you'll find that red is kind of funny, and you'll have to, the more minds involved in some of these designations as the patient goes into the trauma bay, the better. The two sides of surgeon involvement in the triage area. If it's too early, it can create a lot of, if they're there too early, it can create a lot of chaos. On the other hand, when you can take a patient directly from triage/trauma bay to surgery, that's the best case scenario. So what seemed to be the kind of flow is that early in the morning, before patients were coming, or as patients first came, and they were in bad shape, a surgeon's right there. They can look at the patient and say, yeah, let's just take them right back. We don't have to do a lot of stabilization in the ED. That's great. But on the other hand, if surgery's full, the ED's full, the ER's full, if we need surgeons to come out and take a quick look at patients, but we also have to be careful about having 5 doctors stand around the bed for a length of time that interferes with basic care. So you have to figure that flow out too, that's optimal for the patient, not for what we want, not for what you want, but what's good for the patient. Because we all want to be involved, we all want to see what's going on, but that's not always best for the patient. Patient flow is interdependent on all areas of the EFH. I think we're making that obvious here. You also have the normal issues of cultural barriers, language, expectations, and especially level of skill. That will always be a factor in our EFH. What's the national level of skill? Is it good? Is it bad? Is it something we can train, or are these people not really very trainable? And if you know me, one of my big things is trying to get an effort of calm and orderliness in the environment. Chaos, yelling, running, all of these things is not helpful and does not make things better. And so that's something we always want to have someone promoting. And that's why an ED manager, I think, is a really good idea. This is especially true as it regards the national staff, because they take our cues from us. If we show up somewhere and we start running around crazy and yelling and acting like we're not in control, that's what they're going to do. I saw this in Ecuador when a helicopter would arrive and bring patients, and none of these patients that arrived by helicopter at that point were critical. The staff would grab a cart and they would run with all of their speed across the field as if this were life or death situation. That just promotes injuries, it gets people hyped up, and it's not good. So I want you triage officers to keep an orderly, calm environment. That's our goal. In my closing thought, I want you to think about, if you haven't experienced this type of medical disaster care, you will be profoundly affected. it touches each of us. I am so grateful to the Lord that there's no case of one of our staff members having a significant emotional problem. I probably don't know about it if that's the case, but nothing I witnessed. I think we were blessed in that way for a number of reasons. This is difficult, and it can't be understated how difficult this war atmosphere is. And I've kind of coined a phrase I call post-traumatic grief, because I think about it, the things I've gone through since then, even after 35 years of seeing really ugly things, this experience eclipsed a lot of that. Are we disabled by our trauma experience? No. Do I lose sleep over it? Pretty much no. But I do carry a grief around, and I know a lot of my friends that were there do. And so I want to recognize that in those of you that have been there. And I want to encourage you with a passage in Acts 13:47 that says, I've made you for a light for the Gentiles, that you may bring salvation to the ends of the earth. And this is our calling. We want to bring the light of Christ into these very dark places. And this is our high calling, to endure the worst for his best. And we will give it back to him, and we will honor the Lord in all of that. So those are my thoughts on triage and patient flow in the EFH. So I'm going to open it up and let you ask some questions of me.
Thank you so much, Tim. I really appreciate what you've had to share. I've learned a lot, and you've given me an opportunity to reflect on some of my own experiences. I'd like to remind our viewers that there's a chat box on the right of your video, and we invite you and remind you and welcome you to type in your questions, and Tim will be happy to answer them as they come. While we wait for you to do that, I do have a question, Tim. I'm wondering if you would like to tell us, or what you can tell us about the challenge of treating both victims and potential perpetrators of the violence you saw there.
That's a terrific question. We get a lot, of course, when most of us speak, and everybody frames it in kind of their own way. And I'm sure everyone had to consider that while we were there. Literally myself, one day I carried a 6-month-old with a bullet hole through its head back to the convalescent area, and not too many hours later was taking care of some of the suspected ISIS members. So you thought about it. And I can simply say, as a Christian, there but for the grace of God go I. When we understand that the potential for evil in all of our hearts exists, and that all of us have the potential to walk down that road without the saving grace of Christ, it levels the ground a little bit, I think, for us to not be too high and mighty, to make it a little easier to share the love of Christ, and knowing that what we have here, yes, is an evil person having done evil acts, but they also are in deep darkness and they need rescue just like you and I did. For some of us, we have seen some of these kinds of things over the years. I've picked up bodies that drunk drivers have killed in car accidents and things like that. So I've had a little bit, but not to the extent that this evil represents. But God can change our hearts and make us capable of doing this. And some really miraculous things happen because people were willing to put aside those thoughts.
Thank you. We have a question from Alan Sawyer in Togo, and he says, great job, Tim.
Thanks, Alan.
On the topic of moving sicker patients ahead of other patients when the operating room is backed up, how did you decide when to allow a sicker patient to move ahead of other patients?
I can't think of a specific incident, but this generally, in my view, was the decision of the surgeons, what they were capable of doing and how they might do it. So, but it was always in a group. It's never one person. And I think you'll find most triage ethical guidelines will involve multiple people in the decision-making process. So the physicians made those decisions and the surgeons based on what they thought they could do.
Thank you. And Lance Plyler has a question for you, Tim. He came in a bit late he expresses apologies in case you already discussed this. But his question is, can you just briefly elaborate on care for level black?
Yeah, that's a really good question. It depends a little bit on the patient, of course, but we would probably just call it comfort care. They generally were not going to get any medications, although I do know in a couple cases they got pain medication. depending on what happened. We didn't really focus a lot on airway maintenance or that kind of a thing. It was mostly sitting with the patient and praying. Sometimes it was many hours, sometimes it was an hour. But we really didn't do any kind of medical therapies. We didn't insert an airway. We didn't start any IVs. We didn't give any fluids. We didn't do CPR. So not a whole lot.
Thank you. And Timothy Brandt has this question. Tim, maybe to discuss the SP support staff that took the spiritual pulse and treated our staff's emotional and spiritual needs.
Thanks, Boogs, for that question. Samaritans Purse provided a whole level of care, chaplains to be right with us and be right behind us in our care. And the best thing about them is they were also doing this with patients. And so they weren't set aside from the actual pain and misery that we were experiencing. They were experiencing it for themselves, which gave them a great ability to emote with us, understand what we were going through and the frustration, both personally to cope, and then the frustrations we as medical people experience in not being able to do what we'd like to do. That adds another level of frustration. And so SP has great support staff for us to talk to pray with, to be with. And of course, daily devotions, I think, is a major important key to all of us doing well spiritually there.
Thank you. And our good friends and colleagues, Catherine and Andrew Mazzella, express their thanks to you, Tim, and say that was an excellent recap of the EFH experience in Iraq. And I would echo that, although I didn't get to be there. Your experiences of how it impacted you echo what I've heard from many other people. I have a question for you, Tim. What advice can you give to an experienced emergency healthcare provider, someone who has experience from North American settings, who's interested in deploying on an SP DART?
We get this question a lot at some of the conferences when people are showing an interest in being part of the DART team, or they already are and haven't deployed. And my answer is always the same, is that if you don't have any short-term medical missions experience, you need to get some, because it's a pretty big step to go from no missions experience to the EFH, especially in a war context. You can do it, but it's a big step. So I always tell people that being on the DART is a long-term project. You're probably not going to deploy next week or maybe next month or this year. So you need to pursue some short-term medical missions that will get you used to dealing with people in a different culture, dealing with a lack of resources and all the inconveniences that go with it. And you do this over and over again. This will help prepare you for what a DART deployment is like.
And then I have one more question. On the flip side of that would be somebody that has spent years as a medical missionary and is now considering maybe in their, they've left the mission field, but they still would like to deploy on an SP DART. What kind of comments would you have for them?
My first thought with people like that always is that it will be a challenge of your expectations. A lot of people are very accomplished in what they've done or what they're doing. And as with any organization, when you come alongside that organization, you need to kind of understand the ethos and the goals and the concepts that drive that organization. And especially in a DART, your expectation of what you're going to do may not match what you actually do. I've had this happen a number of times, and all of us would admit we have hopes and ideas about what we prefer to do medically. But sometimes it doesn't work out that way. And we have to expect that and be the mature person that will say, God, you're leading me to do this, and you're going to put me where you need me to do this. And so I think that's a caution for those that have a lot of experience.
Great. Tim, I've really appreciated this, and I know our viewers have too. And if you have one last question, anyone, please go ahead and type it in the chat box. In the meantime, I'd like to remind you all that CME credit is available for this session, and the form and instructions are in your email, which you received as a reminder. And we will also be sending a follow-up email with the link to this recording. If you are not on our email list, you can join the forum at health.samaritans.org, and you will then be the first to know about upcoming events. Our next webinar is Wednesday, May 9th, with Megan Vintek. She is an RN that has a lot of exciting tales to tell and some great experience. She, in fact, was the manager of the EFH in Iraq. So we hope to see you then. Thank you so much for joining us.